recorded roundtable meeting of the Senate Health, Education, Labor, and Pensions Roundtable. Thank you so much, Senator Sanders, for hosting this. We're so excited to be here at Morehouse School of Medicine. Our country is at a really critical place. We have to continue to provide health care and health care for all. And so I'm excited that we have a committee that is willing to have hard conversation about the healthcare workforce and the shortage. And we're excited. They're also adding to this conversation the diversity of the healthcare workforce. So I invited myself, Morehouse School of Medicine, and the other three HBCU medical schools, Montgomery Medical College, Carlisle, from our University School of Medicine, because you know they just got their 4-year accreditation. Yeah. And the medical school at Howard University. Historically and collectively, all of your students have trained from Black physicians in this country. So we know our stuff. We know our stuff. And we're grateful to the Health Committee Chairman Sanders and the Ranking Member Cassidy and all the members of the committee, though, to understand that that's not enough. That we're really going to take care of these things and quality of them. They got to be to our institutions and importantly to teach our students and our problems. Please stand, students and residents, and be recognized. Please stand, our residents at Morehouse School of Medicine or any other institution. We are proud of our students. This is our future. We do this in partnership with many. So you're going to hear from David Skorton, Dr. David Skorton, who's the president of AAMC, who's been with us. Give him a round of applause all along the way. And you're going to hear about not just problems, but solutions. And you will also hear us invite
opportunity is all around us.
Us.
But to act on it, you need to get out of your comfort zone. With Grammarly Go, you don't have to take that leap alone.
And we still need more. Because, guys, you know, that Black men, you look at 8% of Black students who are in
Grammarly Go brings AI to every text box,
less than 40%.
helping you produce high-quality writing in a fraction of the time.
It is a
that means no more overthinking email replies.
Black students, Black and brown students that are
no more staring at a blank page.
But we also know
no more waiting until tomorrow.
Get them across the finish line.
Because you have a partner that can help you take the steps to achieve your ambition today.
And we're amazing. Talking about
community is at the core of my business.
About,
Grammarly Go helps you amplify your voice.
All the population in the United States.
Generate ideas.
Talking about how do we ensure that every provider
instantly rewrite until your message sounds just right?
So that when they sit
and go ahead and switch sides,
they can ask me one simple question based on who's sitting in front of me, what's possible.
Giving you the power to unblock whatever's slowing you down.
Not just that person.
And unlock new and unexpected ways to grow.
The other attributes and assets that they have.
Click the blue button to download Grammarly Go today. You'll be amazed at what you can do.
That's what we're here to talk about today. So thank you, Senator Sanders. And now I will close these remarks and turn it over to you. Thank you so much.
Senate Committee on Health, Education, Labor, and Pensions. This is what we do in Washington. I don't know what it means, but a couple of months ago, Dr. Rice was in my office and we chatted about these issues. And I said, let's see if we can do something about it. And this is the very first field hearing that the committee has held. And this is an official hearing. The transcript will be part of the congressional record. And most importantly, I hope that what I and other committee members will learn from this hearing will be translated into law and will have an impact on how we provide healthcare to minority communities all across this country. I don't have to, and I want to give a special thanks to everybody who's here this morning, but especially to the young physicians and those of you who will soon become physicians. You are the heroes and heroines of this moment. You are devoting your lives to taking care of people who are in need in very difficult moment for our country. And I thank you very much for your entering the profession and all of those who are mentoring you as you proceed. I don't have to tell anybody up here. This is not a group of people I have to explain this to. Our current healthcare system is broken, correct? What does that mean? It means that in the richest country in the history of the world, where we should lead the world, people should look to us in terms of what quality, accessible healthcare is. We are behind many, many other countries. In America today, 85 million Americans are uninsured or underinsured. We just went through a pandemic where millions of people lost their jobs. And when they lost their jobs, what else did they lose?
Healthcare.
They lost their healthcare in the midst of a pandemic. Meanwhile, we spend unbelievably $13,000 on healthcare for every man, woman, and child. $13,000. Family of four, $52,000. Who can afford that? It is unsustainable. It is twice as much per capita as do the people of any other country spend. Okay. We pay the highest prices in the world for prescription drugs. And what physicians here know, and younger physicians will learn, you're going to write out a script and your patient will not be able to afford it. How insane is that? But what happens to the person who can't afford the medicine? They get sicker, they end up in the emergency room at a very expensive cost. 500,000 Americans go bankrupt in this country because of medically related issues. You end up in a hospital, you're $50,000 in debt, you make it $30,000 a year, how are you going to pay that? You can't. Then your credit is destroyed. Your family's life is destroyed. We don't talk about it very much. 60,000 Americans die every single year because they don't get to a doctor on time. I have talked to doctors all across this country. Tell me people walk into their offices very, very sick. Why didn't you come in when you first felt your symptoms? What's the answer? Well, I couldn't afford my copayment. I was uninsured. I didn't want charity. Some of those people don't make it. So you are entering a system which is broken. And I know that you will work as hard as you can every day to treat your patients. But I hope we will work together to transform this system. Healthcare is a human right, not a privilege. Then on top of all of that, we're addressing a particular issue today. Unbelievably, we spend $13,000 for every man, woman, and child. We don't have enough doctors. That is a problem that's gone on for years. COVID exacerbated that problem. And we could talk about that, what COVID did to the workforce. We don't have enough nurses. We don't have enough dentists. Dental care is a huge issue we don't talk enough about. People can't afford to get to a dentist. There is, and the young doctors here will learn this soon enough, if you don't know it now, there is a major mental health crisis in this country, again exacerbated by COVID and many other things. Do we have enough counselors, psychologists, psychiatrists? Do we have enough people trained to deal with the terrible problem of addiction? No, we don't. So we have to transform all of that. And in the midst of all of that, the problem is much worse in the African-American community, in the Latino community, in the Native American. Unbelievable. Unbelievably, today, in a population where African Americans are about 13% of our population, about 5% of our doctors are Black, and even fewer, I think, percentage-wise, are dead. Right?
Yeah.
That's why we're here. So what our committee hopes that I'm not making any promises to anybody, because we had a tough political climate in Washington, D.C., as you know. You know, in the midst of this, some geniuses there want to throw millions of people off the healthcare they have, not expand. So we're going to do our best to grow the healthcare workforce and put a special focus on the need for more black doctors, nurses, psychologists, dentists, etc. So that's why we are here today. And I am just really very thankful to Dr. Rice and to everybody here. You know, I don't have to tell anybody here how an extraordinary job the HBCUs are doing, colleges, the medical schools. And it is a story worth telling a million times. So thank you for what you do. We look forward to working with you in the years to come, in the months to come, and the weeks to come. Again, thank you all very much for being here today. Okay, I think I turn the mic over to Dr. Rice. Dr. Rice, thank you very much.
Thank you so much, Senator Sanders. Chairman Sanders, we are extremely proud of our accomplishments and track record. Morehouse School of Medicine and the other HBCU medical schools have consistently been ranked at the top or near the top of all medical schools and social missions. Our institutions have produced the Secretary of Department of Health and Human Services, a director of the Centers for Disease Control and Prevention, and 2 U.S. Surgeon General. And just as importantly, though, numerous physicians and other healthcare professionals who disproportionately and proudly serve people of color in medically underserved communities. We are doing what needs to be done for the American people in a way that is incomparable to other schools. Our mission, though, to train culturally competent providers willing and eager to serve their community comes at a cost. HBCU medical schools do not enjoy the institutional financial resources, academic affiliations, and endowments of other medical schools. But we accept that as a part of our mission, but it leads to be disproportionately focused on us securing support from federal programs that are or should be designed to level the playing field in our ability to train healthcare professionals and strengthen our institutions. We continue to need your committee's help and leadership to continue to position us to make an outsized contribution to improving the health status of minorities and all Americans, which is clearly a national priority. In recent years, Congress responded to health workforce challenges by increasing the number of federally supported graduate medical education, GME positions, through Medicare and the Teaching Health Centers program. Medical schools in general are grateful for the additional positions because they support training opportunities against the backdrop of a national physician shortage. Unfortunately, though, relative few of these additional GME programs have accrued to teaching hospitals or health centers affiliated with historically Black medical schools. So if indeed it is a priority to increase the number of physicians in communities of color and medically underserved communities, there should be specific provisions in each of these programs that direct a meaningful portion of these GME slots to teaching hospitals and health centers affiliated with our HBCU medical. We're asking for priority consideration of such hospitals and health centers will align with the goals of the GME programs and ensure health workforce shortages are being appropriately addressed in medically underserved communities throughout the U.S. Representatives Terry Sewell of Alabama and Brian Fitzpatrick of Pennsylvania have introduced the Resident Physician Shortage Reduction Act of 2023, HR 2389, which would dedicate additional GME positions to teaching hospitals affiliated with HBCU medical schools. And we believe this bill is a good model for the Senate's effort on Medicare and Teaching Health Center GME legislation. However, Mr. Chairman, we have not just been sitting idly, waiting for others to work on our behalf. We have been creating partnerships like the More in Common Alliance, focused on addressing the diversity and the healthcare provider shortage. So I would like to take a few moments of my time left to describe the Morehouse School of Medicine's partnership with Common Spirit Health. This 10-year partnership is the first nationwide initiative between two of the country's leading health organizations to address the underlying causes of health inequity, including underrepresentation of Black clinicians. This partnership lays the foundations for patients to have more access to Black clinicians and for Black medical students and graduates to gain community-based experience. It will allow Morehouse School of Medicine to expand its enrollment, allow us to expand our pipeline initiatives. Common Spirit Health serves some of the most diverse communities in this country and cares for more Medicaid patients than any other health system in the United States. So leveraging our combined 100-year experience, we believe that by opening up 5 regional medical campuses across the country at Common Spirit sites and 10 graduate medical education programs with no less than 2 specialties, one being primary care and another being a specialty area, we believe that we can create a pipeline that creates a pathway from students from those diverse communities to go back and serve in their community. My colleague, and I have to add, this was seeded by a $115 million gift from Common Spirit Health to Morehouse School of Medicine. My colleagues will discuss the importance of other federal programs at the Health Resources Services Administration, HRSA, and the National Institutes of Health that will support our pipeline programs and research infrastructure at our other schools. Once again, we are grateful to your committee for taking the time and making the effort to join us today to examine these critical issues. Thank you very much.
Thank you. Thank you, Dr. Rice. Our next panelist is Dr. Jeanette South-Paul, Provost at Meharry Medical College. Dr. South-Paul.
Thank you so much, Chairman Sanders, for inviting Meharry Medical College to be a part of this committee. And thank you, Dr. Montgomery Rice and Morehouse School of Medicine for welcoming us here. I'm Jeanette South-Paul, the Executive Vice President and Provost at Meharry. And I'm honored to be here today to talk about these critical issues. As an academic family physician who has practiced for more than 22 years in the U.S. Army and then in corporate healthcare prior to coming to Meharry, and who has been an active volunteer leader of minority faculty leadership programs sponsored by the Association of American Medical Colleges for more than 30 years, I recognize the value of intertwining our academic mission with service to the most vulnerable communities. These experiences have informed my comments that I will share with you today. The healthcare workforce shortage in the United States is a multifaceted problem with significant implications for our nation's health and well-being. Our recent and lingering pandemic, declining life expectancy for the first time in our lifetimes, burgeoning mental health crisis, and healthcare workforce that has struggled to stay well and engaged in the middle of these other crises present a call to action for our leaders in government, in healthcare and education, and in corporate America to prioritize our most medically vulnerable. The physician workforce continues to lag behind the U.S. population in terms of race and ethnic diversity, as you've heard from our previous speakers. And so we have more than a third of the population defines themselves as underrepresented minorities, but fewer than 7% of those are physicians, and fewer than 5% are those who make up other academic faculty. These numbers are most acute among primary care, family physicians, pediatricians, general internists, and OBGYNs, as well as psychiatrists and other mental health providers. High-quality primary care is a critical foundation for preserving the health of our nation and cannot be achieved without investment in those institutions most likely to train primary care physicians. So we stand at a critical juncture of our nation's healthcare landscape. At Meharry Medical College, we are working diligently to address the healthcare workforce shortage through a variety of innovative programs and initiatives, but we need the unwavering support of Congress to carry out this mission. To that end, I'd like to highlight some of the policy actions that we would like Congress to take to support not only Meharry Medical College, but our sister HBCU medical schools. As part of our comprehensive approach to addressing this workforce shortage and to improve health outcomes in our most medically underserved communities, let's consider enhancing the infrastructure of our institutions. As my colleague, Dr. James Hildreth, the president of Meharry, testified before your full committee in February, a dedicated allocation of $5 billion for improving research and development infrastructure, for academic health sciences centers at historically Black graduate institutions and other minority serving institutions will represent a monumental commitment to bolstering the capabilities of these institutions to conduct cutting-edge research, develop innovative solutions to pressing health issues, and train the next generation of healthcare leaders. We recommend increasing that funding with a focus on supporting minority serving institutions and their faculty for translational research, which is essential for bridging the gap between scientific discoveries and their practical applications in healthcare settings. This investment will enable us to advance our understanding of the causes and consequences of these healthcare disparities, and then to develop targeted interventions. We know pipeline programs play a crucial role in attracting and retaining students from diverse backgrounds who are interested in pursuing careers in healthcare. And increasing funding and support for pipeline programs such as summer education, enrichment programs, mentorship initiatives, and scholarship opportunities will expose these young people to healthcare careers at an early age. Programs such as Meharry's Goals program, Go Out and Love Science, events in collaboration with the Ascension Foundation and the Medical School Early Acceptance Program, a collaboration between Middle Tennessee State University's College of Basic and Applied Sciences and Meharry Medical College, are examples of innovative initiatives aimed at increasing the number of primary care physicians serving medically underserved populations in rural Tennessee. Federally qualified health centers, something that is very close to my heart because I helped to form the first one in a major teaching institution in Western Pennsylvania, they play a vital role in providing access to quality interdisciplinary healthcare for underserved populations. We recommend updating federal regulations to allow academic institutions, such as HBCU medical schools, to sponsor FQHCs, which can create vulnerable interprofessional health workforce training opportunities for students and trainees in physical, oral, and behavioral health in the same space, so that it's one-stop shopping for the most vulnerable populations and then improve the care of our communities. You see, I'm continue to try to keep on time. Another priority should be building a pipeline for in-demand disciplines such as primary care, behavioral health, maternity care, and women's health that our OBGYN and family medicine colleagues are so embedded and involved with, and general practice and pediatric dentistry. We know the need for maternity care services, which are essential for the health of women and newborns, and it's incredibly urgent, particularly in medically underserved communities. This shortage in urban and rural communities can lead to increased health risks and complications for the people who anchor our families, women and their children. It's particularly disturbing in this country where Black women in the United States are more than 3 times more likely to die in pregnancy, childbirth, and the postpartum year than white women, a gap that persists in spite of income or education. It's also important to highlight the critical need to invest in mental and behavioral health practitioners and research. The current workforce in the field is insufficient to meet the growing demand, particularly in our communities, where the impact of mental health disparities is so profound. And it's not just about numbers of physicians educated in minority-serving institutions, but it's about offering sensitivity and culturally competent care that understands and respects the unique experiences of individuals in these communities. GME programs, such as residencies and fellowships, are crucial for preparing our health professionals to serve in urban and rural communities. This is why Meharry Medical College applauds the bipartisan Resident Physician Shortage Reduction Act of 2023, as you've heard, HR 2389, introduced in the House of Representatives by Representative Terry Sewell, which adds 14,000 new GME positions and amends and expands the policy to give special consideration to hospitals that train as a large share of graduates from historically Black medical colleges, minority serving institutions. In addition, the Veterans Affairs Graduate Medical Education Program offers an unparalleled training ground for physicians, behavioral health professionals, and other associated health graduates, providing them with the opportunity to serve our nation's veterans, which I am one, and of which I have two sons who are serving, while gaining valuable experience in a wide array of specialties. Finally, we must address rural health disparities in our nation, a critical aspect of overall public health that unfortunately is often overlooked. So I will conclude some of my comments to be respectful of time, but say that we are facing significant challenges in training and retaining a diverse health workforce, and we are looking for support for those of us institutions who have demonstrated our ability to serve and to train the next not only today, but the next generation of professionals. The journey's long, the work is significant, but we can ensure a future where quality healthcare is accessible and equitable for all, regardless of race, ethnicity, or geographical location. Thank you for your time, Senator Sanders.
Dr. South-Paul, thank you very much. Our next panelist is Dr. Hugh Mighty, Senior Vice President for Health Affairs at Howard University. Dr. Mighty.
Good morning, and thank you, Chairman Sanders, and thank you to all my colleagues for what is going to prove to be an eloquent discussion on improving the diversity of the nation's healthcare workforce. Our HBCU medical schools are the backbone of training Black doctors in this country, where Black doctors make up only 5 to 7% of all American physicians. The value of our HBCU medical schools' work is more important now than ever before. Howard University has a 156-year history of training minority physicians in this country. More than 50% of these graduates return to work in underserved communities nationwide. Howard also has the distinction of having a college of dentistry, a school of pharmacy, a school of nursing and allied health, and a school of social work. Together, these schools provide a diverse solution to many of the healthcare challenges faced in the nation. As the problem of Black physician shortages rise within the general context of physician workforce shortage, many communities of need will continue to be underserved in the future. Our medical school and our HBCU colleagues have witnessed a surge in the number of applicants to medical school with a limited capacity to accept more. Barriers to growing programs often reside in the high cost of medical school education. These issues faced after medical school graduation are just as significant because there are fewer funded residency program positions than there are graduates. Highly trained physicians who can provide critical medical help to the most underserved communities struggle to find residency programs. The GME dollars are only available for some who graduate. Clinical research is yet another area where HBCUs have been underfunded and therefore restricted in their ability to expand the movement of solutions to communities of color, where trusted voices would lead to better participation in clinical trials. Howard also has a robust undergraduate pipeline via its STEM Scholars programs, which continues to send more Black graduates to medical school each year than any other school in the nation. While addressing physician shortages is one path to solving healthcare disparities in the nation, we at Howard also believe that leveraging a team-based approach of training and deploying physicians, nurses, and advanced practice nurses and pharmacists in working units can do much to extend care within communities cost-effectively and efficiently. Without continued support for these programs, it is unlikely that any of us will be able to meet the country's physician shortage challenge and needs for inclusive healthcare. In closing, I would like to certainly echo what my colleagues have said and which, again, are about to say. One is that we would urge Congress to prioritize and designate graduate medical education positions for teaching hospitals affiliated with HBCU medical schools through Medicare and the Teaching Health Centers program. Legislation introduced in the House of Representatives, the Residence Physician Shortage Reduction Act, H.R. 2389, is a good model for this effort. It designates GME positions for health professional shortage areas and prioritizes slots of teaching hospitals affiliated with HBCU medical schools. An increase in funding and accelerating of funding for HRSA Title VII Health Workforce Diversity programs, particularly with a focus on centers of excellence and the Health Career Opportunity Program. Both programs are currently funded at less than they were in fiscal year 2005. Right-sizing these programs would allow more schools to build meaningful diversity training programs and establish and maintain workforce pipelines programs at health professional schools. We should accelerate investments in the programs of the National Institutes of Minority Health and Health Disparities that improve the research capacity and infrastructure of minority-serving health professional schools. Both the NIMHD research centers at minority institutions, the RCMIs, and the research endowment programs are short funded. The budgets for the RCMIs and the research endowment program should reflect a national commitment to level the research infrastructure playing field at minority health schools compared to those others nationwide. Thank you for your time. Respectfully.
Thank you, Dr. Mighty. Dr. David Carlisle is President and CEO at Charles R. Drew University. Dr. Carlisle, thanks so much for being with us.
Thank you, Chairman Sanders, and thank you for convening this important forum. And thank you to President Montgomery Rice for hosting us here this morning. I bring you greetings from these faculty, the trustees, the students, and the alumni of Charles R. Drew University. We're the only historically Black institution of higher education west of Texas in the great western part of the United States. You know, the main job of a medical school is to train physicians to treat patients in various healthcare settings. As my colleagues have stated, our 4 schools have and continue to serve a unique role in training Blacks and other minorities for careers as physicians, and we do it better than any other set of institutions. A key element in building a diverse and capable healthcare workforce and to study health conditions that disproportionately impact our communities is through the research enterprise that is associated with our medical schools. Collectively, our HBCU medical schools advocated for the establishment of the National Institute on Minority Health and Health Disparities, NIMHD, at the National Institutes of Health to heighten the importance of research and innovation on minority health and health status disparities. Initially, NIMHD was established as a center in the year 2000, and then elevated to an institute in 2010, thanks to the work of Senator Sanders' Health Committee. My colleagues have stated the challenges that face HBCU medical schools in terms of resources, endowment, and financial wherewithal. These challenges extend to our research capabilities as well. And the NIMHD has several programs designed to address improving research infrastructure at minority-serving health profession schools. NIMHD's research centers at minority institutions, RCMI, and the Research Endowment Program, REP, are 2 critical initiatives designed to build research infrastructure at minority-serving institutions. Both programs have been short-funded in recent years. RCMI has not grown at the same rate as NIMHD's overall rate of increase during the last several years. The RCMI program has provided the resources needed for our schools to build a research infrastructure comparable to non-minority institutions, allowing us to attract world-class researchers, expand research facilities, and support cutting-edge investigation into questions about health disparities and how to improve and eradicate them. We urge Congress to prioritize support for the RCMI program and resize the RCMI program to a proportionate level of the NIMHD's budget. In the last Congress, the bipartisan John Lewis NIMHD Research Endowment Revitalization Act was passed into law. Thanks to our local Congresswoman, Nanette Barragan, and to the HEOP committee, the ranking member, Senator Cassidy of Louisiana, for their sponsorship of this legislation. The Research Endowment Program helps our institutions build a research endowment that is comparable to the average endowment of all medical schools. The new Research Endowment Program is supported by only $12 million annually, when historically it had been supported at upwards to $50 million per year. More funding for this program is needed to accelerate the pace of strengthening our institutions. Thank you again, Chairman Sanders, for your leadership and interest in our views.
Dr. Carlisle, thank you very much. Next panelist is Dr. David J. Skorton, President and CEO of the Association of American Medical College. Dr. Skorton.
Thank you, Chairman Sanders, for this and for all you do. Thank you, Dr. Montgomery Rice, for this and for all you do, and to all my colleagues leading these incredibly important institutions that we're proud to have as members of the AAMC. And thank you for the learner who are giving us our future. I'm going to try very hard, Chairman Sanders, not to repeat things that you have already heard about, but just to endorse them. The physician shortage that you mentioned, Chairman Sanders, we estimate by 2034 will be 124,000 physicians. And if your vision for the future came to pass, that everybody had access to medical care, we would right now 180,000 physicians short. So this is a real crisis. It's not getting any better. Since the Flexner report, the HBCUs have been fighting back valiantly to return from a very low point to distinguish things that they are doing now. And I'm very proud of these 4 schools. I learned so much from their leaders all the time. I mean that quite sincerely. We're also looking forward at the AAMC to Xavier, University of Louisiana, and Ochsner Health, opening a College of Medicine. I also want to recognize Chairman Sanders that Morgan State University in Baltimore will open a College of Osteopathic Medicine in 2022. All these added up, the HBCUs are less than 3% of all MD granting institutions, and as Dr. Montgomery Rice said, produce more than 50% of all Black medical graduates. Make no mistake about it, we have been going nowhere in our work to increase Blacks, especially Black men in medicine, except for the HBCUs. My first faculty appointment in January of 1980, and last year, the very same proportion of matriculants were Black men across America. That's a record that I'm not proud of. Through our Action Collaborative for Black Men in Medicine, Chairman, which is a joint effort between the AAMC and the National Medical Association, and through an additional facet of our strategic plan, we're starting to see some improvement in these areas, and a lot of it is due to the leaders you see for you today. I want to switch gears and mention that in the coming weeks, the United States Supreme Court is going to decide on 2 cases about the use of race as one factor among many in higher education admissions, including but not limited to medical schools. An adverse ruling by the Supreme Court would be very detrimental to addressing physician diversity. In the states in the United States where the use of race-conscious admissions has been banned, there's been a 37% reduction in diversity of the classes going forward. And we're here today to say publicly that no matter the ruling of the Supreme Court of the United States, we will continue to push forward for diversity in our country. In addition to our endorsement of the Bipartisan Resident Physician Shortage Reduction Act, which is H.R. 2389 and S. 1302, I want to talk a little bit more about the HRSA programs that have been brought up by our learned colleagues. As was mentioned, those funds have not gone up, they've gone down actually over the last couple of decades. And we support doubling funding for a broad range of HRSA, Title VII and Title VIII workforce. We're urging Congress, Chairman, to provide at least $1.51 billion combined across Title VII and Title VIII programs. We also encourage publicly today increasing federal investment in minority serving institutions, including HBCUs, including predominantly Black institutions, including Hispanic serving institutions, and very importantly, tribal colleges and universities. Of all the many underrepresented in our country in medicine, the Native Americans and Alaska Natives were the only group, Chairman, in the last 2 years where the applicants went up and the matriculants went down. So we need to work on that issue as well. We also support the Expanding Medical Education Act, which would authorize HRSA grants to establish or expand medical schools, including regional branch campuses, and would prioritize HBCUs, MSIs, or those institutions that propose to establish or expand schools in medically underserved communities. Also, the Pathway to Practice proposal and National Medical Corps Act scholarship programs introduced in the 117th Congress, H.R. 9105, would help address the high financial debt for students underrepresented in medicine, This is a daunting thing to look at, especially from early in the education cycle. I want to talk very briefly, Chairman, about learner and physician burnout. We know that burnout and stress on our learners and physicians is real. We have to create a more supportive environment for current and future physicians. I'd like to highlight the Dr. Lorna Breen Healthcare Provider Protection Act, LBAPL 117 to 105, which passed in 2022, but has not been funded. We urge support for this. And we also urge support for immigration programs that continue to bring physicians and other health professionals to underserved areas. We need those excellent physicians and healthcare workers in this country. There's a backlog of green card applications and also J-1 waivers that can be used to bring more physicians, not only to the United States in general, but also to underserved areas. In closing, I want to thank you, Chairman Sanders. I want to thank Dr. Montgomery, President Montgomery Rice, and all here. We have a lot of work to do. Let's get on with it. Thank you.
Thank you, Dr. Skorton. The next panelist is Dr. Samuel Cook, internal medicine resident physician here at Morehouse.
Hey. Good morning, everyone, to the Morehouse students, faculty, and staff, to all those from the historically Black medical schools, to the president of the AAMC, and all the community members who came out today. Thank you so much for coming out for this vitally important conversation. I'm Dr. Samuel Cook, a PGY2 internal medicine resident here at the Morehouse School of Medicine. And I was asked to share some of my story so y'all can get a better idea of what it's like to come up as a resident through the current system. Senator and Chairman Sanders, I come to you today as a fellow American born and raised in New York City. I grew up in the Bronx, New York, born to two loving parents who instilled in me a passion and need to serve my surrounding community at all costs. On my father's side of the family, I was the first cook to graduate from college. And while attending the Johns Hopkins University, I quickly began volunteering at a sliding scale medical clinic in a low-income area of Baltimore aimed solely at providing low-cost to free medical care for families who had limited access to it. However, I struggled to get my foot in the door of more established medical institutions, even with my academic pedigree, because I lacked the familial connections to medicine that so many of my white counterparts had in spades. Nevertheless, I moved forward. I served as a community resource coordinator in East Baltimore, specifically addressing the social determinants of health we so readily take for granted. Access to food, shelter, water, electricity, and employment, all necessary components of health, recognizing that true health is not the mere absence of disease, but a total state of physical, mental, and spiritual well-being. After being told by my undergraduate advisor that my 3.42 GPA at one of the top 10 universities in the nation was not strong enough to support a medical school application, I listened and took a delayed route to my medical education, eventually matriculating to the Drexel University College of Medicine in Philadelphia, Pennsylvania, where I won academic awards and published my medical research. I dove even deeper into medically centered service work and mentorship of young Black STEM students across the nation, ensuring that they would never have to face a lack of supportive guidance or feet in the doors of credible medical institutions. We are here today for such a great purpose. We ultimately want more Black Americans in white coats. So how do we do this? I believe the right approach is, what barriers to entry do we have to dismantle? So how is it right that I'm tasked with providing our community high quality healthcare while struggling to provide for my own family? Why am I struggling financially as a resident physician when I could make a greater hourly wage as a line cook? And I know because I have. And why am I hundreds of thousands of dollars in student loan debt, $320,000 to be exact, when my parents scratched and saved to fully cover my undergraduate tuition? It is because our system is broken. And we, as resident physicians, are not fairly compensated for our time spent saving lives while sacrificing our own well-being. For far too long, we have fallen through the cracks of a healthcare system that blatantly and openly abuses our binding investments into this field, and it is high time that our plight is heard, appreciated, and acted upon. So today, I submit to you that the greatest barrier to entry for burgeoning Black physicians is the immense and seemingly insurmountable financial risk waiting to shackle all those who pass through the gates of medical education. These costs are equally shared for everybody, but the burden they pose is not. It is inequitably distributed as one of many sequelae of generational and institutional wealth inequity. So when the COVID pandemic hit, we physicians of color were asked to run headfirst into a largely unknown crisis, putting our lives, our livelihoods, and the health of our families in the path of imminent danger. And as always, we delivered upon our Hippocratic oath. I am here today to advocate for my fellow physicians of color, those with less than half the generational wealth of our white counterparts. We, the resident physicians of color who have no financial safety nets, should a career in medicine not pan out for any reason. We, the resident physicians of color who have been historically underrepresented, underestimated, and underpaid. It is time for change, and it is time for change today. It is time, Chairman Sanders, for us to get our due so the aspiring physicians in our country may see that they will be fairly treated and protected should they ever choose a career in medicine. It should not be such a financially perilous journey to want to save the lives of others. It should be a decision that is celebrated with words, with actions, and with support from the community level all the way up to our US government. We are not asking for a silver spoon, and we are certainly not seeking handouts. We are simply asking for medical school loan cancellation, free medical tuition for the next generation, and the fair compensation that we are due. Thank you very much.
Thank you, Dr. Cook. Next panelist is, now you put a big burden on this young lady coming up next. Be nice to her too, all right? Sonia Randolph is a medical student year 3 here at Morehouse School of Medicine. Sonia.
Definitely a tough act to follow. Good morning, Chairman Sanders. Thank you for having us here today to listen to us. I just want to tell a little bit about my story. So for some, the topic of Black representation in the medical field may seem like a trivial matter, but for others, it may mean the difference between the life of a loved one. For a young Black couple who presented to the hospital to an all-white healthcare team with concerns that their 5-year-old son was ill, this topic is of particular importance. This couple trusted their son to be cared for by a capable group of physicians that they believed would render quality medical care for him. How could they have known he would be misdiagnosed with a 24-hour virus instead of his actual diagnosis of bacterial meningitis, which proved to be fatal the next day? Why weren't their concerns taken seriously? Why did he not receive the appropriate standard of care? Could this outcome have been any different if he were attended to by a Black physician? The couple in this story are my parents, and the young child was my brother Bryce, and the reason I aspire to be a physician today. So Senator Sanders, it is imperative that we as a country understand the significance of Black physicians providing care for Black patients and other patients as well. Studies show that when Black patients are treated by Black doctors, they are more satisfied with their health care, more likely to have received the preventive care they needed in the past year, and more likely to agree to recommended preventive care. Though the AAMC reports an increase in Black or African-American medical matriculants in 2022-2023, we have even greater work to do. With key factors such as student loan forgiveness, increased exposure and visibility, and mentorship for students aspiring to be in healthcare, we can increase the number of Black Americans in the medical field and subsequently improve health outcomes for Black Americans. According to an article written in the New England Journal of Medicine, children from underrepresented or disadvantaged backgrounds who aspire to be physicians are more likely than their peers to drop their aspirations before the 12th grade, in part due to lack of exposure and cultural, structural, and racial biases in society. Efforts to inspire students from underrepresented backgrounds to pursue a career in medicine should begin at the grade school level. Through pipeline programs, college readiness initiatives, and mentoring opportunities that provide guidance and proctored hands-on activities for students, we can inspire these future leaders to attain their aspirations despite any obstacles encountered along the way. With persistent exposure to careers in healthcare, we will see a significant increase in the number of Black Americans in the medical field. The cost of American medical education has increased substantially over the past decade. Attending medical school without a scholarship can result in hundreds of thousands of dollars of debt. Despite this, students continue to aspire to have a career in medicine. These aspirations are thwarted when students are not able to afford housing, food, and other necessities while in school. The burden of accumulating debt while attending school works to deter potential students from this rewarding career. Learners need student loan debt forgiveness, increased funding for scholarships, and more financial support for our HBCU medical schools to be able to afford to continue their education. We can achieve this goal with a substantial increase in Black American representation in the medical field. But it will take more individuals like you, Senator Sanders, and the HELP Committee to achieve. Thank you.
Last but not least, and thank you, Sonia, very much. Dr. Jamil Joyner, who's a medical student here at Morehouse.
Good morning, everyone. Thank you, Senator Sanders. Thank you, all of my co-panelists. All of your words were beautiful, and you've given me a great task to close us out tonight. I don't know if I'll be as eloquent, but I'll try to be as pointed and as directed to what I believe are the solutions for how we increase diversity and ultimately health outcomes for our Black, Latino, and underrepresented communities. Myself, I am a third generation HBCU graduate, soon to be double HBCU graduate in a week or so. So I don't know if there's anyone that could tell you all anymore how vital HBCUs are as a cultural and economic pillar, not only within the communities they reside in the West End, but in the Black community at a large. Studies continue to show that HBCUs are disproportionately responsible for producing Black educated graduates as well as Black professionals, disproportionate to the size of their position within the larger college body, as well as their proportion of Black students that they educate. That shows that these institutions are not only vital to the number of Black students that they produce, but they're better at it. We're better at it. And we're better at it for obvious reasons. While answering the question of how to improve Black health outcomes is multifaceted, we know that one answer is increasing the number of Black providers. And we know that the place that produces the most Black providers are HBCUs. Not only do Black providers, Black patients do better with Black providers, we know that Black providers are more likely to go into primary care specialties as well as practice in underserved areas of need. I believe that Black schools, HBCUs, are the key to increasing the number of Black providers, as has been mentioned, due to their unique capability, commitment, to educating these providers, as well as the relative feasibility of increasing their capacity to do so. In 2018, 2019, the AAMC published that roughly about 1,250 Black or African-American identifying students graduated from the U.S. medical schools. Out of roughly 150 of those U.S. medical schools, 3 and now 4 and 5 and hopefully more as we go are HBCUs. So we're talking about 2% of the total schools. But that year, they produced roughly 250 to 300 of those Black educated students out of that 125, We're talking about 2% of the schools producing roughly 20% of the efficiency, not just historically 50% total, but to this day, these institutions right here, as was mentioned, without them, there would be no progress. There would be no maintaining of our current status quo, which is in. These facts aren't just to laud how great these institutions are. It's to show the potency of what resources, finite resources that we all are very familiar with that we have, can do at these institutions. We're talking about potentially increasing these institutions' incoming classes by 50%, having a total 10% increase in the yearly production of Black physicians, let alone other providers. Dollars here go further than dollars everywhere else, because what we do here is better than what they do everywhere else. Every year, thousands of capable applicants to medical school are denied, hundreds of which are Black. While a universal increase in the number of medical school matriculants is needed, we know that increases at HBCUs would, one, translate most directly to an increase in Black physicians and Black providers, as well as, again, two, require a relatively small amount of capital and infrastructure support. Improving Black health outcomes begins with increasing Black representation within healthcare. And the most effective way to do that is to support the growth of HBCU medical schools through direct capital funding for physical infrastructure expansion and increased operating expenses. Thank you.
Thank you. Thank you, Jeanette. What I want to do now is kind of open it up. And if it's okay with you, what I'd like to do is ask you guys some questions, and then you can ask me questions as well. But let me say this, and I'm going to get in trouble for saying this, but I often get in trouble, but this has been really one of the more extraordinary panels that I've ever been involved with. And I'll tell you why, frankly. You know, Harvard and Yale are great medical schools, and we appreciate all that they do. But at the end of the day, speaking just for myself, what we need in this country are medical schools and doctors who are prepared to go out and serve people who are in need. I am sure that they need more plastic surgeons on Park Avenue in New York City. But I can think of many other parts of this country where there are zero doctors, where people are dying. Women are traveling 100 miles to see a doctor when she's giving birth. And we need doctors who are prepared, in medical schools, who are prepared to train those who are going out serving the underserved. Now, this panel has raised just a whole lot of questions. And just one point I want to touch on. Why we must significantly increase the number of doctors. We didn't talk about nurses, dentists, got to do all that. Mental health counselors, got to do that. All right, with a special focus on Black and Latino, Native American medical health personnel. We have got to answer questions like, I think you raised, Dr. Cook, the issue of the determinants that result in life expectancy, lower life expectancy. So it's not just healthcare. So if you're going to be treating somebody who does not eat or have a decent diet, somebody who's working 60 or 70 hours a week for minimum wage, you know what? The likelihood is that that person is going to have a significant lower life expectancy than somebody who has money. And here is a statistic, this goes beyond race. This is a statistic that is absolutely shocking. While life expectancy, correct me, is declining in America, the difference between the people on top and working class Americans is 10 years. Poverty in itself is a death sentence. So, I mean, we have an enormous amount of work to do. This is the wealthiest country in the history of the world. People, we should not have 500,000 people who are homeless, et cetera, et cetera. All right. So I want to thank this panel. It's been a great panel. And we are going to take your testimony and do our best. I'm not making any promises, but we're going to do our best to incorporate your ideas into legislation. Okay, let me start off my question, then you ask me a question. We've heard the issue of student debt. Does anybody think it is vaguely saying that at a time when we desperately need more physicians, especially Black and Latino physicians, that we're asking people to leave school, medical school, $300,000 or $400,000 in debt? All right, who wants to talk in the audience about student debt, what it means to whether or not young people are going to become physicians, where they're going to practice as physicians, and the stresses on your family? Who wants to talk about that for a moment? Don't be shy, guys. I see a hand right here.
My name is Rebecca
Oh,
Shafani.
Rebecca, speak closely into the mic, please.
My name is Rebecca Shasani Ellis. I'm a graduate of Morehouse School of Medicine, MPH 2009. Student debt. Having been someone who came into the health field knowing that I was committed to underserved communities, I went out and I served in North Philadelphia. I've served globally. Student debt still follows me today. I am a nurse and I'm even faculty at one of the top nursing schools in the country. But student debt still follows me. What needs to be done about student debt? Some of what's facing us right now, like the legislation to forgive debt for those who've been serving in nonprofit and even public service positions, that needs to be pushed. That needs to be pushed back. That it's time to recognize that those who have been historically disenfranchised, those who come from minority and even low-income backgrounds, they need relief from the debt so that we can keep doing the good work that we've begun.
Yeah.
I think another crucial thing that was raised by the panel is that supporting pipeline programs. Pipeline programs are so key. It prepares young people to understand what's the road ahead. It helps them to understand the varied field of healthcare. So medical education is one part, nursing education is one part, going to dental education, et cetera, and even mental health is another part. And then the other part of it is financial literacy. I think a lot of the programs need to build in and even updating the capacity of minority serving institutions and HBCUs to talk about financial literacy with their students. How can I remain in underserved communities working and still have the wherewithal to pay down my student loan debt?
Okay. Rebecca, thank you very much. Okay. Somebody have a question for me, which I'll try my best to answer, or push on to somebody else who might have a better answer. Yes.
Thank you very much, Senator Sanders, for being here and the panel here. So your question has to do with what is it like to finish medical school free of debt? Well, I stand as one of those individuals who, as my cap shows, was from University of Texas Medical Branch in Galveston. And when I finished medical school and did my residency there and graduated, I had $5,000 back in there 50 years ago in the bank. I had no debt. What it did for me at that point was to allow me to go to the Gaza and serve at a Southern Baptist mission without thinking about paying debt. To spend a year and a half at the University of Nairobi teaching in the surgery department, free of debt. To come to Morehouse School of Medicine in Atlanta, Georgia, as a person without debt, to give lovingly and kindly and empathically to the patients that I saw and to the two students that I taught, to the learners that I taught. So what it means that I had no debt. Therefore, I could give freely what had been given to me. Thank you.
All right. Another question. Somebody raised the issue of salaries for residents. I spoke to residents at the University of Vermont Medical School. They were telling me they were working 70, 80 hours a week. I hadn't realized how residents were really almost maintaining the local hospital. Didn't know that. So when you get elected to the Senate, you actually begin learning things. And they were making, as I recall, something like $62,000 a year. So if you work, is that roughly what you got?
Spot on.
Pardon me?
Yeah.
Okay. All right. So what does it mean? And if you have a family, you're working very long hours and you're making $62,000, what impact does that have on your life and your ability to go forward? Wants to address that one? Yep.
Thank you for your visit, Senator Sanders. I'm Dr. Ivonye. I'm the Associate Dean of GME. I oversee all. Thank you. Okay. I oversee all our residency training programs. I would say I live with these residents. I know what they feel. PGY 1s make about 50,000, PGY 2s about 63,000. And it goes up and up by about 2,000. Some of the residents have families. They have relatives. They have student loans. They have other obligations, inflation, and shrinkflation. Everything's affecting our residents. They work long hours, taking care of our patients, the most vulnerable. And talking to them, they're not earning livable wages to sustain what they do. I appeal to you to please take the message back to the Senate that our residents deserve better compensation to live well. You said poverty is a disease and a threat to long life and prosperity. Thank you.
Yep. Okay, anybody want to ask myself or anybody up here on the panel a question? Okay.
Thank you. Thank you for being here, Chairman Sanders, and hosting it, Dr. Montgomery and the panelists. It's a question in regards to the residents, but not so much about the payment. And anyone in the panel could answer it. I've been hearing, and we've all been hearing a good amount about how you guys plan to pretty much increase the number of students in medical institutions and having regional places as well in different, states. But I was hoping you guys can reiterate what are we going to do, or what do you guys plan to do about these available spots in the residency programs? What point is it to increase the amount of students in medical institutions if the spots are still limited in the residency programs? Thank you.
The answer is, as you have heard, every year there are thousands of students, and somebody up here correct me, who graduate medical school cannot find a residency spot, which is at a time we're in desperate need of doctors. That's, again, slightly insane. Welcome to the United States Congress. In Build Back Better, which was a major piece of legislation which would have dealt with many of the issues we're talking about here today, which lost by 2 votes, we substantially increased the numbers of GME slots. I think by about 14, was it 1,400? Yeah, I think 2,000, was it? 2,000, which would have gone a long way to address this issue. The other thing that we're trying to do with graduate medical education slots is to put an emphasis on primary care. We want to encourage medical schools to graduate students who are prepared to serve in underserved areas. There's a major crisis in doctors in general, especially in primary care. So we wanted to address that as well. And I hope that within the midst of the GME issue, we can deal with the issue of salaries for residents as well. The other thing we're doing is a program called the Teaching Health Center Program, which will allow, right now, residents are usually attached to large medical facilities, hospitals. What we want to do is give residents the opportunity to get their education in federally qualified health centers as well. And that's a community health centers and primary care. So that's a program that is expanding. We want to substantially expand it. One program we did not talk about, in the American Rescue Plan, we tripled funding for the National Health Service Corps. Is that something you guys are familiar with? All right. And that is a model that says if you are prepared to serve, I think it's 5 years or so in an underserved area, we will forgive your student debt. So we want to substantially increase funding for that again. But the bottom line here is I think everybody has said, at a time when we desperately need physicians, we especially need African-American and Latino physicians. We need to have physicians serve in underserved areas. The idea that people are graduating medical school, hundreds of thousands of dollars in debt, which prevents them from doing the work you heard the previous gentleman talking about, his ability to go to places he wanted to go. He couldn't do that if he was $500,000 in debt. So there's a lot of work to be done, and that's some of the issues that we'll be addressing. Okay, other questions, comments? Yes. I'm sorry. Yes.
Hey, how's it going, Senator Sanders?
Good.
Yeah. My name is Ty Chambers. I'm an artist and an entrepreneur. I'm currently in the MPH program here at Morehouse School of Medicine. And I just wanted to ask you a question about universal health care. And so, Gavin Newsom over in California, he's been doing some great work.
Hold that mic a little bit closer to you.
Gavin Newsom, he's in California. He's been doing some great work as far as getting health care for Americans in that state and also undocumented immigrants. I just wanted to know, as a sitting U.S. Senator, how soon do you see something like that in the single player healthcare system coming into fruition federally?
Oh boy. On Wednesday, this coming Wednesday in DC, I will be meeting with, I think, several hundred doctors and nurses to announce that we will be introducing a legislation for a Medicare for all single payer program. But I want to, and I think it's important. Look, I have enormous respect, unbinding respect for the people up here and you who are devoting your lives to serving the underserved. And that's what you're going to have to do. But I'm even asking more of you than that. You can knock your brains out 24 hours a day doing fantastic work, saving lives. And yet if you have a system that is totally broken, the situation overall is not going to improve. We got to change the system. So what are the basic tenets? And this, what I'm telling you now, and what you all know, is not a radical idea. All right? We spend twice as much per person on healthcare as any other country. With the amount of money we spend, every American, child, elderly person should have quality healthcare. That's what we should do. You asked me that question. All right? It's a very political question, and that's all right. We're allowed to be involved in politics here too. I do that occasionally. All right. What does it mean? The system today, the healthcare system today, is working really good. For the insurance companies and for the drug companies, they're making tens of millions of dollars a year. It ain't working so well for working people, for low-income people, for people of color, for young doctors. So what we need to do, and I'm not going to give you a 3-hour speech on this, I could, because I believe in this passionately. What we need to do is very simply create a healthcare system designed to provide quality, affordable healthcare to all as a human right, not a system designed to make huge amounts of money for insurance companies and drug companies. It's not a radical idea, all right? You all understand. I want you to understand. You practiced in Canada, all right? You know how much people have to take out of their wallet to walk into your practice? Zero. They go to a hospital, they got a serious illness, they're in a hospital for a month, they walk out, no bill at all right? And yet they spend half as much per capita as we spend on healthcare. All right. So as we go forward and as you do the enormously important work you do, taking care of your patients, we also need to understand that we have to change the system, but the opposition there is enormous. The people who are making the money want to maintain the status quo. It's working for them. And as I can, as a politician, talk about this 24 hours a day, you as physicians will have more impact on this debate than I will have. You will say that you want to treat all the patients who walk into your door, not just those who have the money, right? You don't want to see people walking in the door who should have walked in the door 6 months before because they didn't have insurance. So we need your help on that. Yes, ma'am.
Good morning. My name is Dr. Day. I'm an internal medicine physician. I'm one of the faculty members for the GME program. But my question is to Dr. Skorton and also the leaders of the HBCUs here on the panel. I think one of the things that we need to address in terms of making physicians more culturally competent is getting rid of the racist medical education that exists. So what is being done about changing the curriculum? Because I feel like even as someone who is Black, what I learned in medical school was inherently racist, if we're going to be honest. And even growing up as a Black person, I can't change that. But what I was taught sort of changed my thinking sometimes. And so I will tell you, there's been times when I've had bias that I really couldn't believe because I'm like, well, it's in conflict with who I really am. But that's the education that I was given. So what is being done about that curriculum, or how can we address that? Because I think that's also important.
Thank you very much for raising this. And before I answer real quick, I just want to say, Senator, everything can't be on you. We have to work with you in the private sector to make this work. You can't do everything yourself in Washington. This is unbelievably important, and this is what we're trying to do about it. Obviously, we're not getting the job done yet. Out of our strategic plan, we have a specific plan based on this. If you grab me right afterwards, I'll tell you how to find out more about that, get involved, criticize it, write to me, and so on. That's one thing. Secondly, periodically, very periodically, the AAMC will send out a suggestion to all the 157 medical schools. We don't tell them what to teach. Those curriculum are developed appropriately by the faculty locally. But we will say, here's some competencies that we think are so important that we'd like you to consider putting them into practice. And just a few months ago, we sent out diversity, equity, inclusion, and anti-racism competencies. That if you haven't had a chance to see them yet, I'll also tell you how to find them. If you want to have some fun, I introduced those competencies in an op-ed with the Dean of the University of Miami School of Medicine, Henry Ford, and the editorial board of the Wall Street Journal took after us saying that this was all baloney, there's no such thing as embedded racism and so on. And so if you want to have some fun at my expense, read that exchange that we had. But we're beginning to work on it. It's unbelievably important to do that. Since I've garnered the floor, two more quick things, Chairman. One is about the resident situation. Are the residents employees? Are the residents trainees? And the answer is yes. And so we always have a resident on the board of the AAMC. At our last board meeting, we had a long 74-slide presentation by the residents, 3 of them from the Organization of Resident Reps, that gave us basically what Dr. Cook gave us, but wasn't limited by that little clock going off in red. And we're just starting to tackle and figure out what that is. And the last thing about the debt is, I was a college president twice, and somehow every curriculum, whether it's English literature or physics, takes 4 years. That can't just be a coincidence. This is just sort of the way things have always been. And there are experiments going on, Chairman, with different lengths of medical training. Tuesday of next week, I'll be on Long Island giving a commencement to the second graduating class of a 3-year medical school where everybody does primary care. And I'm not saying everybody can do that, but that kind of experimentation, we can't leave the whole thing on the back of the U.S. Congress. Thank you for the question.
I want to comment also on this. And so Dr. Skorton said something very important early in his talk. regardless of what happens with SCOTUS, we're going to continue to work to diversify the healthcare workforce. Regardless of what the Wall Street Journal and others say, we're going to ensure that we have a curriculum that helps us to move through our conscious and unconscious biases, which really do begin early on. And so many times we're having to unravel once we get into medical school. But we are trying to make sure that we expose our learners to all of the opportunities to ask that question based on who's sitting in front of me, what's possible. And it does mean that you have to deal with diversity, equity, inclusion, and racism, because that is what this country has been founded on. And so we have to begin to unravel and unmantle this. And then I will just ask you all to believe that there's hope. You all remember the NCAA, what is it, the basketball, all of the sports, right? And you know, these college athletes have made a lot of money for what? For colleges and universities. And they finally are starting to recognize, right, that that was inequitable. And so we are recognizing that we are paying our residents for a service that doesn't align with their efforts. And I know that Congress is going to work with us to be creative in how we can increase the wages. And that's what we need to do, because you should make a living wage that is reflective of you being able to live and care for your family and not incur all of the debt. We also have to recognize we have to create more programs to forgive debt or for debt to be relieved based on the service that you have performed.
Okay. 2 points. Number one, my staff mentioned to me that we would have increased GME slots by 14,000 over 7 years. That was the number that I wanted. Number two, I've got a plane to catch, maybe 2 more questions, and I apologize for that. But we're not going to be able to take all the questions. So just the first 2 people. Yes, ma'am.
Good morning, Senator Sanders and panel. I'm Veronica Mallett. I am the Chief Administrative Officer for this historic partnership between the Morehouse School of Medicine and Common Spirit Health to increase diversity in the healthcare workforce. And my question is a follow-up to our previous questioners and the panel about what we can do as citizens in light of the pending SCOTUS decision and in this current political climate where there is a denial and an attack on fact. And given that, what can we do as citizens, and what would be your recommendation? Because again, you can't do this alone. So how can we help? How can we advocate?
Well, I think you know the answer. And by the way, let me thank the people of Georgia for giving us 2 excellent United States senators. I would not be here as chairman of the committee if the people of Georgia had not done what they did. And that is what we have to do all over the country. Georgia actually is doing better, maybe than any other state in this country, in bringing in people who often do not get involved in the political process. Lower income people, people of color, standing up and fighting back. We got to do that in Texas. We got to do that in many, many states in this country. The ideas that we are talking about, which are being live streamed, I suspect a few 100,000 people may watch it. People say, nothing radical about this. This is what we should be doing. But so many people have given up on the political process. You know them. You see them every day. They don't vote. They don't, they say, nobody cares about me. Why would I want to vote? And we've got to bring those people into the process. We got to elect people who are going to stand up and fight for them, make a difference in their lives, to show people that actually democracy can deliver for ordinary Americans. That's the challenge that we face. But thanks for the question. As to individuals who lie all of the time, I will not name any names, will not mention presidents who have been pathological liars. I wouldn't do that. But I mean, this whole thing, and artificial intelligence is going to make it worse. It really is. It's one thing to debate facts, right? You can have difference of opinion. Another thing, somebody's lying all the time. Tough stuff. But I'm not mentioning any names. Yes, ma'am.
Good morning, Senator Sanders, Dr. Montgomery Rice, and the panel, and every white coat in this building. I want to say thank you for your service. I am the product of the Morehouse pipeline into the Health Informatics Master's Program. So I want to say thank you for that opportunity. My question is for the panel. In light of what Senator Sanders just said with AI and the increase of technology in the medical profession, how do health programs that train health informatics, master's degree students, and health administrators and policy thought leaders figure into the funding that you all have mentioned here?
I think my colleague who spoke to research infrastructure, I mean, I want to give you the opportunity to speak to that. I think that is where the key is. So it's not just about getting you in the door. It is what is going to be the experience when you get there.
I would love to comment that informatics, as we know, anchors everything we do in healthcare because it's the beginning of how we gather data. And data provide us the facts that allow us to appropriately look forward towards how we can make a difference. At Meharry Medical College, we have a new school, the School of Applied Computational Sciences. And that's a school that is now prioritizing how we manage data and integrating with their Enterprise Data Analytics Center, how we then gather the data, especially for populations that are most underserved. So I think that inextricably linking those two things together is important. I was fortunate to have just recently co-chair the National Academy of Medicine VA Whole Health Committee. And what we are trying to do is get whole health, comprehensive, not just physical, behavioral, spiritual, integrative health implemented not only for veterans, but for all of our populations. And one of the anchoring things was having an electronic data system that will allow us to have the data we need. So there are many efforts going on to show how important what you do is to allowing us to, if we don't measure it, we can't change it. If we don't measure it, we don't know what's going on. So all of those are so important for our vulnerable populations.
All right. Let me just thank Dr. Montgomery Rice for hosting this event. Let me thank the representatives of the great HBCU medical schools who are here, the students, the faculty. Let me thank all of you. I think this has been a great panel, at least I've enjoyed it. It's been a great discussion. The American people want us to succeed on this, all right? They perceive the crises that we're talking about today. So let us go forward, let's work together, and let's bring the kind of change in this issue and so many others that the American people want to see. Thank you all very much for being here. Listening in who wish to ask additional questions. Questions for the record will be due in 10 business days on May 26th, 5 p.m. Finally, I ask unanimous consent. I'm the only person here. I think I'll get it. To enter into the record 4 statements from stakeholder groups related to the conversation today. The committee stands adjourned. Thank you all very much.